Hello, citizens of Internet. I am Dr. Ajit Virkud from Mumbai, India. I am a professor and ex-head of Department of Obstetrics and Gynecology. This is a channel that gives something extra. This podcast is inspired by the success of my textbook, which has been widely received by students and professionals alike. Each episode will delve into selected excerpts giving voice to my structured approach to topics in gynecology. Whether you're a student, a seasoned practitioner, or simply interested in the field of gynecology, I hope you will find these discussions both enlightening and engaging. Thank you for tuning in, and let's explore the world of gynecology together.
Welcome to the deep dive. Today, we're focusing on something that, might really hit home if you've ever dealt with persistent pelvic pain or discomfort. We're doing an in-depth exploration of pelvic congestion syndrome, PCS for short.
Right.
You might also hear it called Taylor syndrome or pelvic venous insufficiency, sometimes even pelvic varicocele. It's kind of the female equivalent of a varicocele in men.
That's a good way to put it. And it's really important we talk about this because, honestly, chronic pelvic pain can be just incredibly challenging.
Yeah.
And often misunderstood. You know, finding the actual cause can take a long, long time. And PCS is one of those conditions that isn't always top of mind immediately.
Absolutely. So our goal today, and we're drawing heavily from Professor Ajit Virkud's textbook, Modern Gynecology, is to really get a handle on PCS.
Right.
We want to look at, how common is it? What causes it? What are the signs, the symptoms you might actually feel? How do doctors diagnose it these days? And maybe most importantly, what can be done about it? What are the treatments? It's actually pretty amazing when you think that before we had things like Doppler ultrasound, figuring this out was a real clinical puzzle.
Oh, absolutely. Before Doppler, clinicians were really relying mostly on, the patient's story, their history, and whatever they could find on a physical exam.
Right.
Which, as we'll get into, can be pretty non-specific when it comes to PCS. Being able to actually see the blood flow, that really changed the game for diagnosing this accurately.
So let's start with that first point. Just how common is this? Professor Virkud's book suggests PCS might be the main reason behind chronic pelvic pain in up to 30% of women who experience it.
Yeah.
I mean, stop and think about that. Almost a third. That feels like a really significant number. It suggests it could be way more common than maybe we've traditionally thought.
It really is a striking figure. When you think about just how many people suffer from chronic pelvic pain, saying up to 30% might have PCS as the root cause. Well, that's a huge proportion. It definitely underscores why it needs to be on the list of possibilities, the differential diagnosis, when evaluating someone with this kind of pain.
So what's actually going on? What are the mechanisms behind PCS? Let's get into the why, the etiopathology. The textbook says the basic issue is faulty veins, basically varicose veins, but deep inside the pelvis.
Exactly. And what's interesting is the specific location. It's the dilation, the widening of what's called the pampiniform plexus of veins.
Okay.
Sort of picture this network of veins around the ovary, draining blood into the main ovarian and uterine veins within the broad ligament. In PCS, these veins get enlarged, twisted, really just like varicose veins you might see in someone's legs.
Huh.
And that leads to this congestion, this cooling of blood, and the pain that comes with it.
And it sounds like the body's actual plumbing, the anatomy, plays a part too, especially how the veins drain on the right versus the left side.
Precisely. The anatomy is quite relevant here. So the right ovarian vein drains straight into the big vein, the inferior vena cava, and it does so at quite an acute, sharp angle. But the left ovarian vein, that one drains into the left renal vein, the kidney vein, and it joins it almost at a right angle.
Oh, interesting.
Yeah, and that difference in angle, particularly on the left side, might actually create a bit more resistance to blood flow. It could make it harder for blood to drain efficiently, possibly contributing to that congestion building up.
And pregnancy. The book really highlights pregnancy as a big factor. It sounds like the changes the body goes through during pregnancy can kind of set the stage for PCS later on for some people.
Oh, definitely. During pregnancy, the blood flow to the whole pelvic area increases massively. The textbook mentions around 60%.
Wow, 60%.
Yeah, it's a huge increase. And all that extra blood volume puts a lot of pressure on those pelvic veins, causing them to stretch, to dilate.
Right.
And for many women, those veins might not completely snap back to their original size after the baby is born. Plus, this effect can sort of add up. Subsequent pregnancies can make it worse, potentially leading to this chronic state of pelvic congestion.
That's really something to think about for anyone who's had, multiple children and is having this kind of pain. What about hormones? Estrogen is mentioned too, with PCS being more common before menopause.
That's another piece of the puzzle, yeah. You think about it more broadly, estrogen is known to affect the tone, the sort of stretchiness of blood vessels.
Okay.
So the higher levels of estrogen floating around before menopause might make those pelvic veins more likely to dilate. And then after menopause, when estrogen levels drop off, that could partly explain why we see less PCS then. The veins might regain some tone.
Are there other things, like maybe your family history or other conditions that might make someone more likely to develop PCS?
The book does point out a couple of things. First, if you have a family history of varicose veins, like in the legs, that seems to increase your risk. It suggests maybe an inherited tendency towards weaker vein walls in general.
Right.
And second, it's reported to be more common in women who also have polycystic ovary syndrome, PCOS.
Oh, really?
Yeah, though the exact reason why those two might be linked isn't fully clear yet. It's still something being looked into.
Okay, so we're getting a clear picture of what PCS is and maybe who's more at risk. Now, let's talk about how it actually shows up, the clinical features, the symptoms that would make someone think, okay, I need to see a doctor about this.
Right. The typical person we see, as described in the text, is often a woman who's had children, usually under 45. And there are several key complaints that come up again and again with PCS.
Dyspareunia pain during sex is mentioned, often described as an ache that sticks around for, up to 24 hours afterwards. That sounds like it could really impact someone's life.
It absolutely can. It's often a very significant symptom for patients. And then there's the chronic pelvic pain itself, which is really the hallmark.
How is that pain usually described?
It's typically a dull, aching feeling, but the pattern is important. It often gets worse just before a period or during it.
Okay.
And also significantly with prolonged standing or sitting. Many women find the pain just sort of builds up as the day goes on.
Are there other, maybe less common symptoms?
Yes, there are. Things like low backache can be related. Sometimes painful periods, what we call dysmenorrhea, or even abnormal menstrual bleeding. Some women report vaginal discharge or symptoms like an irritable bladder, feeling like they have to pee frequently.
So it sounds like it can present in quite a few different ways, which I guess makes it tricky to diagnose sometimes.
Exactly. And when a doctor does an examination, they might find some clues like fullness or noticeable varicose veins in the legs or even on the vulva. Interestingly, the uterus might be tilted backwards, retroverted, and sometimes it feels a bit cystic or boggy. The ovaries might also be tender when examined.
What really jumped out at me from the textbook description was how ambiguous these symptoms can be. It says the pain can involve both the pelvis and the abdomen, which apparently leads to people getting sent to all sorts of different specialists, surgeons, gastroenterologists, pain clinics, physios, before anyone even thinks it might be gynecological.
This is such a critical point for listeners to grasp. Because the symptoms aren't always screaming gynecology problem, people can end up on this long diagnostic journey seeing specialist after specialist.
Yeah.
And unfortunately, in some cases, the text notes people might even get referred for psychiatric assessment.
Oh, wow.
Before PCS is ever really considered. And all this means significant delays in getting the right diagnosis and the right treatment. It's a real issue.
That must be incredibly frustrating and probably isolating, too, for the person going through it. So once suspicion is raised, what are the actual steps doctors take to confirm it's PCS and not something else?
Well, the first inkling usually comes from that pattern of symptoms, the clinical picture we just talked about.
Right.
But to really nail the diagnosis and, importantly, rule out other things that cause similar pain, imaging is absolutely key.
Pelvic ultrasound, especially with color Doppler, seems like a main tool here. What are they specifically looking for on those scans?
So the ultrasound lets us see the veins directly. The color duplex, the Doppler part, lets us see how the blood is flowing.
Okay.
For PCS, we're looking for pelvic veins that are dilated, usually wider than 5 millimeters. We look at the resting blood flow speed, often over 5 centimeters per second. And crucially, we look for reflux.
Reflux meaning blood flowing the wrong way.
Exactly, backward flow. We test this by having the patient do a Valsalva maneuver, like bearing down gently. If we see blood flowing backwards in those veins in the annexal regions around the ovaries with a peak speed over to 2 centimeters per second, that's a strong sign of venous insufficiency, which is central to PCS.
What about CT or MRI scans? The book says they can show the veins but not the flow.
That's correct. CT and MRI give great pictures of the anatomy, They can clearly show if there are dilated, twisty veins down there.
Mm-hmm.
And they're really useful for making sure there isn't something else causing the pain, like endometriosis or PID or fibroids. But they don't really assess the function of the reflex problem. That's where Doppler ultrasound or venography comes in.
Ah, okay. And then there's pelvic venography or an ovarian venogram. That's described as the gold standard. Why is that considered the most definitive test?
Pelvic venography is a bit more involved. It's minimally invasive, though. A contrast dye is injected into the pelvic veins, and then X-ray pictures are taken.
Oh.
This gives a very clear map of the veins and critically shows exactly where and how much blood might be flowing backwards, the reflex. It's gold standard because it gives the most detailed info on both the anatomy and the function. Plus, it can be used after treatment to make sure the reflex is gone.
Laparoscopy is also mentioned. That's surgery, right? How does that fit into diagnosing PCS?
Yes, laparoscopy is keyhole surgery. If someone is having it anyway to investigate chronic pelvic pain, the surgeon can look directly inside.
I see.
They might see the dilated veins in the broad ligament or near the ovaries. But often, its main value here, as the book points out, is actually finding other conditions that mimic PCS symptoms, like spotting endometriosis or signs of past infection, PID, or maybe an ovarian cyst.
Got it. And lastly, pelvic angiography is mentioned but rarely needed.
Very rarely. Angiography looks at both arteries and veins in detail. It might be considered in, unusual cases if there's a suspicion of an abnormal connection between an artery and a vein in the pelvis, an arteriovenous malformation, which could also cause issues. But for typical PCS, it's usually not necessary.
Now, there's a really, really important point the textbook makes. Just seeing dilated pelvic veins on a scan doesn't automatically mean someone has PCS. It can apparently be found in people with no symptoms at all.
Absolutely. Essential distinction. Yes.
Yeah.
You can't diagnose PCS just based on an image showing wide veins. That can be an incidental finding.
Okay.
The diagnosis really requires linking those imaging findings with the symptoms of chronic pelvic pain and making sure other possible causes have been ruled out. It's often a diagnosis of exclusion in many ways after careful workup.
Okay, that makes sense. So we've figured out how it's identified. Let's move to the crucial part for anyone suffering.
Yeah.
How is PCS treated? What kind of relief can people actually expect?
Right. There's actually quite a range of approaches, from medications through to surgical or interventional procedures. The medical options generally aim to shrink those dilated veins or break the pain cycle.
Vasoconstrictors, like ergot alkaloids, are mentioned. How do they help?
Vasoconstrictors do what the name suggests they constrict, or narrow blood vessels.
Okay.
So the idea is to reduce that abnormal widening in the pelvic veins, which can then ease some of the pressure and congestion causing the pain.
And hormones are also used, things like medroxyprogesterone acetate or GnRH analogs like goserelin. What's the thinking behind using those?
The main idea with hormonal treatments is to suppress ovarian function.
Right.
If you reduce the ovaries activity, you lessen the blood supply going to that whole pelvic area. And the hope is that this reduces the congestion in those faulty veins. It can be effective for some women in managing their symptoms.
Then moving on to the surgical side, there seem to be a few options. Laparoscopic bilateral ovarian vein ligation, maybe with removing tubes and ovaries too.
Yeah.
What does that involve?
So this is keyhole surgery again. The surgeon goes in and finds both ovarian veins and ties them off, ligates them.
Okay.
Sometimes, depending on the situation, the tubes and ovaries might be removed as well. That's the salpingo-oophorectomy part, but that's less common just for PCS itself. The main goal is just to stop blood flow through those congested, leaky veins.
What about ventral suspension? The book mentions it, but calls it obsolete for PCS. What was that, and why isn't it done anymore?
Yeah, historically, there was this idea that if the uterus was tilted backwards, the retroversion, it might be pulling or putting pressure on the ligaments containing these veins, causing pain. Ventral suspension was surgery to reposition the uterus forward.
I see.
But later research just didn't back it up. It showed it wasn't actually an effective treatment for PCS pain, so it's fallen out of favor. It's not recommended now.
And pre-sacral neurectomy, that sounds more involved.
It is. That's a bigger operation where specific nerve fibers in front of the sacrum, the ones carrying pain signals from the pelvis, are cut. It can sometimes help with severe chronic pelvic pain that hasn't responded to anything else, but it's not specific to PCS, and it does carry its own potential risks and side effects.
Then there's ovarian vein embolization or sclerotherapy. These sound less invasive.
They are, yes. These are done by interventional radiologists usually. For embolization, they thread a tiny catheter, usually from a vein in the groin, up into the faulty ovarian veins.
Wow.
Then they deploy tiny coils or a kind of medical glue to block off those veins from the inside. Sclerotherapy is similar, but involves injecting a solution that makes the vein wall scar up and close off. Both basically aim to stop the blood pooling in those veins without major surgery.
The book also mentions a local anesthetic injection into the hypogastric nerve plexus for temporary relief. That sounds like it could help with diagnosis, too.
It potentially could, yes. The pain relief from that kind of nerve block is only temporary, of course.
Right.
But if someone gets significant, even short-term relief from it, it does suggest the pain is likely coming from that pelvic area, which can be useful information.
And finally, hysterectomy, removing the uterus, is mentioned as a last resort, but with a big but.
A very big but, yes. While removing the uterus might be considered in really severe or difficult cases, the textbook is very clear that it's often not effective for PCS unless those congested ovarian veins are dealt with at the same time, either by tying them off or embolizing them.
Ah, okay.
If you just take out the uterus but leave the underlying vein problem, the pain can unfortunately just continue.
That's really important to know. But it is encouraging that the book says outcomes for the right treatments are generally really good, like over 75% pain relief and low recurrence.
Yes, that's definitely a positive message.
Yeah.
It shows that once PCS is correctly identified and properly treated, whether that's medically or with embolization or ligation, the majority of patients do get substantial relief.
That must make a huge difference to their quality of life.
A massive difference, absolutely.
So wrapping things up, the textbook really drives home this point. Okay, lots of people might have dilated pelvic veins without any symptoms, that's true. But PCS itself is probably still under-recognized in people who do have chronic pelvic pain. And not considering it, not confirming it with the right test like Doppler, can lead to real problems for patients.
Exactly. It can mean, as we discussed, bouncing between specialists, having lots of tests that don't help, sometimes even getting misdiagnosed with psychological issues, or, really sadly, being labeled as drug-seeking.
Yeah.
When actually there's a real physical condition going on that needs proper medical or interventional treatment.
Okay, so just to quickly recap our deep dive on pelvic congestion syndrome. We've learned it's a definite cause of chronic pelvic pain due to varicose veins deep in the pelvis.
Right.
It could affect maybe up to 30% of women with this kind of pain. Things like pregnancy and estrogen seem to play a big role. The symptoms vary, but often include that pain with or after sex, and a persistent dull ache that gets worse with certain activities or times of the month. Diagnosis relies on symptoms plus imaging, especially ultrasound with Doppler to see the reflux. And treatments range from medication to minimally invasive procedures like embolization or surgical ligation, which thankfully seem to work well for most people.
And I think thinking about the bigger picture, for anyone listening who has chronic pelvic pain, it really highlights how complex that journey to diagnosis can be.
Yeah.
And potentially how long it might take before PCS is even thought of. So the importance of doctors just keeping this condition in mind, including it in their thinking when they see patients with this pain, well, it can't really be overstated. That awareness could potentially save people years of frustration and unnecessary suffering.
That's a really powerful point to end on. If you or perhaps someone you know is dealing with persistent pelvic pain, it definitely seems worthwhile to bring up the possibility of pelvic congestion syndrome with your doctor. Thank you for joining us for this deep dive.